Hi, class of 680. This is our presentation of bipolar disorders with Derek, myself, Mackenzie, Shauna, Kyle, and Kayla. So, when looking at the essential tools and facts for a clinician when it comes to diagnosing bipolar disorder, many times or oftentimes that it can be overlooked or it can go to a severe diagnosis rather than being depressed. So, say if somebody was diagnosed with depression, they can actually have the possibility of having bipolar disorder, but just because they were already such in a depressive state, that was the only thing that the doctor had focused on instead of looking at the manic or hypomanic symptoms. So, once it comes to an understanding that there's a possibility of it being a bipolar disorder, the client could actually ask further for um, more screening tests, more tests to be done to observe every new episode with an antidepressant failure. And once that's accomplished, a psychiatrist can go back through the diagnosis and actually confirm that with the depressive episodes, it could increase the risks of manic or hypomanic symptoms because oftentimes when somebody's diagnosed with bipolar disorder, they're such in a depressive state that other environments such as like mental genetics environmental factors can play a role into the diagnosis, and in turn the psychiatrist can go back and through and evaluate that all in its entirety.
Okay, and now we are going to talk about assessments, and I have three that are really important. So the first one I want to talk about is clinical interviews, which is very common and normal for not just bipolar disorder, but whenever a clinician is first meeting with their clients. With these clinical interviews, they're always conducted mostly by your counselor, the providing clinician, or even a psychiatrist if you went to a psychiatrist first instead of going to a counselor first. These are open-ended questions. It builds rapport. And a lot of the questions they ask you are open-ended, so that way they can ask you to elaborate on your meanings and see if that fits underneath the diagnostic TM, the DSM-5 like diagnostic criteria. And a lot of times these questions are just how does your day-to-day life go and how do you respond to certain behaviors? What kind of behaviors do you have? When did it start? How long have they want to follow for? Just so they can really see what's going on in your whole life and fully understand it. And then I want to discuss behavioral and functional types of assessments, which focuses on observing one's sleep patterns and tracking those sleep patterns, one's day-to-day activities, as well as how the disorder affects their life, because that will show kind of what if it's bipolar one or bipolar two, as well as show how much it is affecting them, which can then also help out with figuring out what kind of medication can be best for them. If medication can be best for them, what kind of treatment plans do they really need? If they think they just need to do medication with counseling or really intense counseling, that's where behavioral and functional assessments do come in handy because it shows really how you are being affected each day. And then the neuropsychological testing is important because that one focuses on the on client's memory, their concentration, and how they problem solve in their day-to-day life, as well as how it can affect different disorders a client has. So this one is really important if a client has a differential diagnosis or if they think there might be a differential diagnosis, and that can help determine if these signs and symptoms are bipolar disorder or a different diagnosis, or if there's already two, which one is affecting which part of their life. And this one also will monitor the medication that they are taking, which is helpful because it shows is the lithium doing its job? Is it actually impacting you positively or is it impacting you negatively as well? If you're taking other medications, how are those medications interacting with one another? So I feel like neuropsychological testing is really important when someone has been diagnosed with bipolar disorder already and they might have a differential diagnosis or they're kind of seeing a new psychiatrist. This one can be good to see kind of how the body is working when they already have done like the clinical interviews and the behavioral function assessment. Now I'm going to talk about the misconceptions. So for mood swings, one of the biggest misconceptions about bipolar disorder is mood swings and how someone is just in a constant mood swing and how they can go from happy to angry within the flip of light switch, which is completely not true. And that is not how it works. One does not automatically just wake up and is mad or pissed off and then goes right back to being happy a day later. their manic episodes will last for weeks on end, and it's a constant mood that they are in. It's not just like up and down, it's constant, and that's why it is called a manic episode because they are in that one episode for such a long period of time. Or a mood swing is someone getting upset at you for like knocking your drink over, snapping at them, and then going back to being happy. That's a mood swing. Bipolar disorder is not a mood swing. The next misconception I want to talk about is that those with bipolar disorder are violent and dangerous, which I feel like is a misconception because of the media. Media always depicts those with bipolar disorder as running away with their kids, such as in Shameless with Ian Gallagher, which that's not how that actually works. Yes, some can become violent and dangerous to themselves if they are not on medication, and that is not their fault. That might not be always the case, but someone cannot get medication, then yes, they might not know how to manage their emotions properly, and it could lead to violent situations. But they don't just start off as violent and dangerous. It's because they're not given the proper techniques and tools to manage their symptoms and signs. And then that's what leads me to my third misconception is that medication is the only way possible to treat bipolar disorder, which is not true at all either. A lot of misconceptions with mental health is that you need medication to get better, and that's the only thing that's going to work, which isn't true. Medication helps monitor, yes, the signs and symptoms and help one control it, but without proper treatment, proper counseling, and proper grounding techniques, they're not going to be able to actually see how the medication is helping and are not going to be able to get to the next step further. It's just going to monitor it and kind of keep it in a closed, contained box. But if they're not doing the proper treatments that a counselor would give them, they're not going to be able to contain that box forever, which is why medication being the only way out is not a good fact. And it's a really popular misconception because you cannot cure bipolar disorder. It does not just go away. You work through with your psychiatrist or your counselor with both medication and treatment.
Okay, so moving on to diagnosis, the definition of that, the populations that it affects, the criteria for that, and then the cultural considerations for all of those things. So the definition, as characterized by the NIMH, is dramatic shifts in mood, energy, and activity levels that affect a person's ability to carry out day-to-day tasks. Also, mood and energy levels being more severe than normal ups and downs that are experienced by everybody. Already, a cultural consideration for that is that what is socially acceptable can vary from culture to culture. So you can often get, for instance, African American or Hispanic individuals misdiagnosed with bipolar because, yeah, so moving on to population. 2.8% of US adults have bipolar disorder within the past year, with a similar prevalence between men and women. 2.6 experiencing a severe impairment. Among teens, the condition was found to be slightly more common in females than in males. So the criteria for bipolar 1, it's broken up into two sections, bipolar 1 and bipolar 2. For bipolar 1, you have to meet the criteria for one lifetime event of a manic episode. A manic episode is a period of at least 1 week that is persistent throughout that week of an elevated mood or increased irritability beyond the normal range of that person. Some of the symptoms of that can include an inflated sense of self-esteem or grandiosity. It can be a decreased need for sleep, being more talkative than usual, having racing thoughts or ideas, and importantly, this has to cause some sort of social impairment or vocational impairment, which makes it different than hypomania. Uh, Moving on to bipolar 2, it is one lifetime event of hypomania and major depressive disorder, or a major depressive episode. Uh, as I said, the hypomania is similar to mania, except that it's shorter in duration, only needing to be 4 days, and also that it doesn't either make some sort of impairment socially or vocationally or require hospitalization. If either of those things happen, then it becomes mania and puts it over into bipolar 1 instead. Also with bipolar 2 having a decrease or a major depressive episode, which would be a decrease in those things. So low self-esteem, low motivation, persisting for at least a week.
And now we're moving on to the research. And so, when looking into the research and researching the research on what is going on with bipolar disorder, what I found was there was a lot of older references to 14th century, 15th century. So research has been going on for a long time, but I really focused on trying to narrow down to the last couple centuries. And so when you really look into some of the progress that was made, and I guess I'll reference this too, it was really hard to find some true idea on what the research is, but the research really was done in person, seeing individuals. It was a hands-on thing as far as the research that was done, and they didn't have a lot of technological advancements to be able to do the type of research that we can do today. So through this earlier research in the 19th century is when, ironically, two individuals in France were studying the same thing at the same time and came up with the idea of bipolar disorder and looking at it in different ways. And so Jean-Pierre Fabre uh, was actually referencing something that Kale was talking about with the mood swings and called that circular insanity, to where I guess the change in the mood going back and forth repeatedly, and that's why he thought it was called circular insanity. It's what he came up with. But exactly around the same time, Jules Ballinger, these names, Ballinger, I'm a butcher him, did dual form insanity, where I guess he was talking about both sides going on, not necessarily in the same time in a circle, but just seeing both sides. So through the earlier research, these were things that were found out. Later on, through more research and study, Emil Kraepelin came up with the manic depressive part, which we used up until 1980 or 90s. They ended up, well, no, I'm sorry, till later on, just recently, they actually phased out the manic depressive for the newer DSM-5s. But then Carl Jung was real big on making the last stages of just kind of diagnosis through research. And this is where Kyle was speaking about earlier about bipolar 1 and bipolar 2, just being able to differentiate the differences in the levels of the bipolar and what dictates those differences in bipolar 1 and bipolar 2. But the one thing that I really noticed too is pharmacology was a little bit different. There really were a lot of baseline things, not a lot of advancements earlier on. And this led up until probably the mid 20th century. And so the main things were alkaloids, bromides, barbiturates were the main thing, which is why I think we still see them today, and chloral hydrate. These were more the pharmacology options that were used until we've made more advancements through research. Moving on to the new research, uh, really a lot has been made as far as progress since really 1950s. So this last, century really has made the big difference moving from the 20th century to the 21st century. And so some of the things that I noticed really through that was that um, there was a lot of research that really built up in the late 20th century and it made a lot of progress up until maybe towards the end of the century. And then it kind of backed off. It really took a break there for a while. And it was really about collecting information still the same way as old research with, the information gathered through experiences with those individuals who have been diagnosed with bipolar disorder. But the big things that I really took from that was there was a lot of pharmacological advancements that were made. And even through those advancements, there was still some discrepancies through research on people deciding whether some of these advancements were still worth it or not. And the big one that I looked into was earlier on, they felt like lithium was really a great option. But then later on through research, they have not been able to find any efficacy to using it because the results that came from the research and studying what people had given as far as information, the data just wasn't compiled and comprehensive. And I think that's the big key is research needs to make more advancements. And they believe that through my study that more research needs to be done as far as this goes, but they really got to build on the databases in a better way to be able to do consistent, good research. It just kind of took a break there over the last 20 years and has really backed off. But the one thing that seems like it's making some great headway was genetics. Genetic research has really made some great advancements over the last 30 years, 40 years. and they're finding out a lot of specific details about it. But the harder part that they found through a lot of the genetic research is it's kind of this overlap also with other disorders that aren't necessarily bipolar disorder, schizophrenia, is other things. But they really just said that the biggest thing to that is being able to really just narrow these things down. We just needed to get more information, more definitive information, and comprehensive information that's put into these databases to get the best research there needs to be. So there is a push lately to get more research and better research. So.
All right, and I'm moving on to treatment. So the two main areas of treatment are pharmacology and psychotherapy. And it is noted that pharmacology is the most effective for bipolar disorders. And then second in line is the psychotherapy. For pharmacology, there's three main areas of medication that is prescribed for individuals with bipolar disorder. So that starts with lithium, then there's anticonvulsants, and then atypical antipsychotics. For psychotherapy, it is noted that psychotherapy is a wonderful tool as a part of treatment for individuals with bipolar disorder only when the individual is stabilized. So this may or may not include a hospitalization, but once they are stabilized on medication, then they want to introduce the psychotherapy. So the three different areas of psychotherapy are psychodynamic, there's solution focused, and cognitive behavioral therapies that they identify are the most effective with this population. Another area is family therapy. So oftentimes family members do not have the knowledge of how to, like, what the symptoms are, how to communicate effectively with a family member with bipolar disorder, and how to make the home life and environment safer area for the individual. So family therapy is also very beneficial. And now interesting facts, starting with eye changes. So there was a study done by Parker, and they noticed that it is easily able to tell from a clinician or a family member what stage of the bipolar or what stage the individual is in, whether it's a manic stage or depressive stage, by just looking at their eyes. So in the manic stage, they tend to say they have sparkling eyes where there's more light reflective in the eyes versus the depressive episodes where there's less light in their eyes. They feel that this is due to the decreased thickness of the retinal fiber layer, which that allows those eye changes to be noticed. Weather. So interesting enough, there's a correlation between sunlight and warmer weather and clinical outcomes for individuals with bipolar disorder. And this includes increased hospitalizations with the warmer weather and sunlight. And they are attributing that to having the weather trigger manic episodes. So the warmer it is and the more sunlight there is, individuals have a tendency to then become manic, which would lead to the increase in hospitalizations. And writing style. So Forgeard completed a study on the differences in writing style between individuals without a mental health disorder, individuals with disorder or a diagnosis of depression, and individuals with a diagnosis of bipolar disorder. And they realized that individuals with bipolar disorder speak or write about death more often than individuals with a diagnosis of depression and individuals who do not have a mental health diagnosis. They found that this was interesting since it's thought that oftentimes the writing typically happens during manic episodes, which typically include the elevated moods. So it was interesting to see that even during those elevated moods, there was significance that there was more words regarding death in their writing styles. And that is all we have in regards to our group project for 680 on bipolar disorders. And we look forward to you watching this.